It's well established that it's easier to obtain a good quality ultrasound view of the vertebral canal in a parasagittal oblique or PSO view compared to a transverse midline or TM view, particularly in patients who have challenging spinal anatomy. Good quality ultrasound views mean a view in which we can see the anterior complex or AC. If we can see the anterior complex, we can be absolutely certain that the ultrasound beam is penetrating a soft tissue window and has entered the vertebral canal. And so our needle will also be able to enter the epidural or intrathecal space through the same soft tissue interlaminar window. Anytime the anterior complex is more easily visible in the parasagittal oblique view than the transverse midline view, this implies that the paramedian interlaminar window is wider than the interspinous window. A paraspinous approach is therefore more likely to be easier and more successful compared to a midline interspinous approach. This is often the case in patients with narrowed interspinous spaces from suboptimal positioning, narrowed interlaminar spaces from degenerative spine disease, or with anatomical deformities such as scoliosis. As I've previously described, one way to use ultrasound imaging to mark for a paraspinous needle approach, especially in subjects with poor quality images, is to identify and mark the neuraxial midline based on the spinous process shadow in the transverse midline view, as well as the transverse plane of the spinous process. The needle is then inserted 0.5 to 1 cm inferior and lateral to the intersection point of these two lines, with a 10-degree lateral to medial angle, and then the tip is walked cranially off the lamina as needed. However, more recently, I increasingly mark for a paraspinous needle approach using a maneuver which I call spinning on the AC, or the SPAC maneuver. It provides for more precision in determining an appropriate needle insertion site and trajectory. The spinning on the AC maneuver is demonstrated here on an elderly patient who was discovered on pre-procedural ultrasound scanning to have degenerative spine disease with severely narrowed interlaminar spaces and a rotational lumbar scoliosis. We were, however, able to obtain a good image of the anterior complex in the right parasagittal oblique view at the L5-S1 space. Having identified the anterior complex, the probe is carefully and slowly rotated from a longitudinal orientation into a transverse orientation, making small sliding adjustments as needed to continuously keep the echogenic line of the anterior complex in view. This allows us to be confident that the hyperechoic line visible in the transverse midline view is actually the anterior complex, even if it is off to one side of the neuraxial midline, as in this example. Center this on the screen using the M-mode center line as a guide, and mark the position of this on the patient's skin as shown. If your skin markings are accurate, a needle inserted at right angles to all planes should enter the canal without difficulty. However, you should anticipate some inherent inaccuracy in skin marking, especially if the patient has very mobile skin. So it's not unusual to contact bone, which will be the lamina. I often enter deliberately just a little bit caudal to my marks to deliberately contact the lamina of the inferior vertebra. As expertly demonstrated here by my fellow, small, controlled, and incremental cranial redirections will walk the needle tip into the interlaminar space. This is signaled by the tactile feel of ligamentum flavum. Progressive advancement will inevitably result in dural puncture. Note the subtle angles of the final needle trajectory. I'll illustrate this with a second example, this time in a patient with very challenging anatomy due to previous spinal surgery and progressive scoliotic deformity. A parasagittal oblique scan on the left side showed that the paramedian interlaminar windows were narrowed and closed. On the right side, however, we identified open paramedian interlaminar windows as evidenced by visible anterior complexes, which was consistent with a scoliotic curve convex to the right. We selected the anterior complex at L3-4 as it was the easiest to see, and then we performed the spinning on the AC maneuver. rotating the probe into a transverse position while keeping the anterior complex visible. The anterior complex was centered on the screen using the M-mode guide marker, and the position of the ultrasound beam was marked on the patient's skin. Spinal anesthesia was successful with a single pass of a spinal needle inserted at right angles to all planes.